Okay, thank you very much for this invitation. I'm glad to be here. And this is yours. Is this one? Okay. Then in the next minutes, I will talk about cognitive impairment and apathy in Parkinson's disease, but I would like that we have progressed in the recognition of cognitive impairment in Parkinson's disease as own manifestation of the disease. We also have recognized the state of mild cognitive impairment in Parkinson's disease as a risk factor to evolve to dementia. And also, we have to acknowledge that not all patients evolve to dementia, and we are going to talk about this. But also, we are involved in an ongoing work to define different trajectories of cognitive decline, just to refine and individualize the prognosis of the patient that comes to our consultation and say, okay, you are saying that I am having mild cognitive impairment, then in the next 2 years I am going to become demented, and perhaps this is not true, and to find more appropriate treatments for this cognition. Then in the following slides, I aim to just to show you the importance of apathy in the context of this cognitive impairment, of apathy as a non-motor symptom, and the relationships of apathy with cognitive impairment and also with decision-making in non-demented patients with PD. And my final end is to postulate that apathy should be taken perhaps as a biomarker, both to define a different trajectory of cognitive impairment in Parkinson's disease and also as a selection criteria for potentiated drug trials of cognition in Parkinson's disease. First, it is rare or striking that this is a very recent cartoon for a very important person in Parkinson's disease, and then here we have mild cognitive impairment. Here we have dementia, but it seems that we have no apathy in the evolution of Parkinson's disease. And then, wow, I'm not sure whether this is the next one. Okay. We have two types of cognitive impairment in Parkinson's disease. We can define a domain-specific cognitive impairment that occurs in early stages of the disease and is characterized by relatively subtle deficits in specific cognitive areas, that is, recall memory, visuospatial processing, attention, concept formation. But this cognitive impairment is not extensive enough or severe enough to qualify as dementia, affects almost all PD patients, and also may qualify as mild cognitive impairment according to the new MDS criteria for mild cognitive impairment. And as I have said, it has a variable progression to full dementia. And then the other one that we also have criteria of the MDS Society and also may accomplish DSM-4 or DSM-5 criteria for dementia is severe and extensive, occurs late in PD, is strongly related to age, and is characterized by the addition of more Alzheimer's type signs of cognitive impairment, that is more posterior cortical deficits, as we can see, for instance, when we use specific scale separating this executive impairment that was said to be characteristic of Parkinson's disease, and now we acknowledge that the transition to dementia in Parkinson's disease is characterized at first by a progressive and steady decline in executive functions, such as verbal fluency or working memory, but of an abrupt decline later in the evolution of more posterior cortical tasks, such as clock drawing or confrontation naming, that are more Alzheimer's disease type of cognitive impairment. And perhaps this is strongly linked to other additional neuronal loss and problems with neurotransmission, in which cholinergic levels are very important and are these alterations in cholinergic innervation that nowadays we know that is typical from the early stages in Parkinson's disease in many patients, is more related to the degree of cognitive impairment than to the years of evolution of the disease. That is, that not necessarily you will have this, but it is strongly related to the presence of cognitive impairment. And I don't know you to read all these busy slides, but in particular, from the neuroimaging point of view and also from an anatomical point of view, this extension of mild cognitive impairment to dementia is strongly linked to the alteration of temporoparietal regions in addition to frontal atrophy, and these that can be observed, for instance, in this very important study, could be followed by imaging and maybe also a biomarker in therapeutic studies of mild cognitive impairment for selecting samples with high risk of progression to dementia. That is, cognitive impairment may be characterized as the passage from a relatively subtle cognitive impairment with visual perceptual and attentional executive dysfunction to visual perceptual and attentional executive dementia, in which, for the first part of the slide, the contribution of dopaminergic deficits is very important, and for dementia, there is a crucial contribution of a non-dopaminergic system. This may have many legs, and we can more or less separate the contribution of dopamine that is partially responsible for the dysexecutive syndrome, noradrenaline that contribute to impaired mood and attention, serotonin to depressive mood, and acetylcholine explaining impairments in these more posterior cortical functions, but also, of course, the boundaries between these systems are not strictly defined. But what we have learned, and this is an important slide of an important study, is that besides age, that is the more important risk factor for the progression of cognitive impairment in Parkinson's disease, neuropsychological tasks that are of more posterior cortical basis, such as semantic fluency, inability to copy, explain the evolution to dementia, and patients with also predominant dysexecutive fluency, frontally based altered task, are not associated with dementia risk. That is, there may be different trajectories for this problem that we call mild cognitive impairment that affects almost 1 every 4 patients that come to our clinics. And the main risk factor, as you can see, is older age at assessment and older age at disease onset. But this is a classification according to the Peterson criteria, and nowadays we have other types of classification. Perhaps Maricruz is going to talk about this. I'm not going to define this, but importantly, it demands that besides cognitive impairment, subtle difficulties on complex functional tasks may be present. And here you have the different instruments that are recommended. But basically, this has 2 types of categorization. One is type 1, using only cognitive rating scales, and the other one is type 2, that is a more comprehensive examination of 5 domains using 2 tests for domain. Then, if the patient accomplishes these criteria, for instance, this is a recent study using these criteria, and you can see that the amount of patients that can be classified as mild cognitive impairment in incident patients without dementia of Parkinson's disease is impressive. It's more than 1 in 4, it's almost 1 in 2. But it also depends on how you use 2 standard deviation criteria, 1.5, and this is an ongoing work, and also there is a task force that is dealing with this. But the problem is that if we do not define which is the more malignant type of cognitive impairment, whether it is only these executive problems or multi-domain cognitive impairment, we are not going to select the correct sample for the future drug trials that are our goal in the next future. For instance, this is the first double-blind trial of using rivastigmine, that is, as you know, it's a cholinergic drug. But if we say, okay, cholinergic is very important for cognition, why rivastigmine is not running? And perhaps this is both not selecting an adequate sample just to show that some patients improve because they have cholinergic deficits and some patients do not, but also perhaps using not the correct instruments because they use it an Alzheimer's disease instrument. But this is just to show that it is very important to know which type of cognitive impairment has the patient, and also that this myriad of non-motor symptoms and also of psychiatric symptoms is very important to consider that does not occur in isolation. And then cognitive impairment occurs in conjunction with other non-motor symptoms, and of course we are going to deal with apathy in this talk. If we take a big sample of patients with Parkinson's disease, we can see that almost 50% has apathy. Then this is a very important problem, and this was not only shown by us, but also other studies. And also if you make a cluster of the different neuropsychiatric symptoms, one cluster is patients having apathy more than depression and anxiety. Another is depression more than anxiety, anxiety more than depression, and the final, not very large cluster of psychosis and psychomotor. But the more clear cluster is these patients that have a lot of apathy, and in this sample, apathy is not presented in isolation. 41% of this non-demented sample also have cognitive impairment and dysexecutive impairment. That is, the two phenomena are presented or are presenting together. And what is apathy? Then apathy refers to a set of behavioral, emotional, and cognitive features that are characterized by this reduced interest and participation in the main activities of daily life. The third day of a meeting of CIBERNED is some apathetic meeting, we can say, because there is a lack of initiative and a trend toward early withdrawal from initiated activities and also indifference. But apathy is a multidimensional problem in Parkinson's disease, and probably it requires a multidimensional approach because it has different components. One component is reward deficiency syndrome. Another is emotional distress. Both are linked. Another is executive function, because as we can see, or we are going to see, it is very linked to this executive impairment, and still there is an autoactivation deficit in apathy. Then there is a variable contribution of at least 4 major components of goal-directed behavior, and sometimes they occur in isolation, and you can characterize which is the patient with more autoactivation deficit, or but more frequently, they occur in combination. And why care about apathy? We can be apathetic, as the cartoon that I showed to you. Apathy does not exist. Perhaps Lang was apathetic the day that made this cartoon. But 45% of these patients, that is a very big sample of patients, and this is a classic study now, has apathy, and apathy is the symptom with the highest impact on quality of life of this patient. Then there are also other studies showing that apathy is associated with greater functional impairment than depression and even than mild cognitive impairment. Then Other examples, here you have a lot of neuropsychiatric symptoms and non-motor symptoms. 73% of patients has neuropsychiatric symptoms in this sample, but the only symptom with statistically significant association with ADL when you correct for motor symptoms is apathy. Then I expect that I have convinced you that apathy is important in Parkinson's disease. Then some examples of our work with apathy. One is what adds apathy to the cognitive behavioral profile of non-demented PD patients. Then we are going to examine the emotional affective component of apathy. And then we did this study, and we observed that facial emotional recognition is impaired in patients with Parkinson's disease who have isolated apathy. This is a sample that is not very easy to recruit because patients that have apathy in isolation are not very frequent, and you have to be very strict with this criteria. And then this patient has no depression, has no cognitive impairment, but still they have a disruption of emotional affective processing that is highly selective because it affects some emotions and not other, and in this case, negative emotions such as fear, anger, and sadness. That is, you know that emotion recognition is heavily dependent on the amygdala and the anterior cingulate cortex, and then we can conclude that these patients may have failures in this emotional component, and these differentiate them from non-apathetic patients. Then what adds apathy to the reward deficiency syndrome? Is there a reward deficiency syndrome in Parkinson's disease? As you know, an important problem today is impulse control disorder in patients with Parkinson's disease that is associated to the use of dopamine agonists. And then we make this study of decision-making and cognitive impairment in Parkinson's disease. This was not focused on apathy, but interestingly, what we observed was that there was an impaired decision-making in treated non-demented PD patients that didn't have depression or ICD. But the more cognitively preserved patients, that is, all patients had no cognitive impairment, but there are subtle differences that still are significant in spite that they are not accomplishing dementia criteria of mild cognitive impairment. And there was a nice correlation with the Iowa gambling task with the MATIS, in the sense that the more cognitively preserved patients did worse on the Iowa gambling task. That is, here there is a relationship and a link between this and a paradox also. This paradox can be explained by the extra doses of dopamine that levodopa or other cognitive or other dopaminergic agents are causing in different areas of the basal ganglia. As you know, the dorsolateral prefrontal cortex is depleted from dopamine, but the frontal limbic or the orbitofrontal is not so. And then if the more cognitively impaired patients have more denervation of the limbic system, then they are not going to show this deleterious effect that patients that with more cognitively preserved function and supposedly less denervation are showing, and this happens also with cognitive function that we are not going to use. But it is important to take this into account because when we examine a different sample just focusing on apathy, and we can show that apathy is more than just executive dysfunction, and when using appropriate tools, apathy may differentiate patients with a subclinical pattern of cognitive impairment. And in this study, we showed that apathetic patients performed significantly worse in cognitive tests than non-apathetic patients, but still within normal ranges of the different scales, cognitive scales that we use for these patients. And surprisingly, or not so surprisingly, apathetic patients that did worse on executive function performed significantly better and within normal ranges in reward-related tasks. That is, you have to interpret this in the context of the previous slide, in the sense that perhaps apathetic patients has a different pattern of dopaminergic denervation with more dopaminergic or more extensive denervation of the mesolimbic circuits that preserve these patients to the overdose effect that we observe in more dopaminergic preserved patients. How we can examine this phenomenon from other point of view. Then we did this study just using a Gehring gambling task, that is, you make bets, and we observe how you react to losses. And this is a Gehring gambling task, and you can use this feedback-related negativity that is larger after unfavorable outcomes. It do not measure favorable but unfavorable outcomes. And normally, when you win heavily or when you lose importantly, then the next trial you have a more conservative response. And here is the feedback-related negativity in all the sample, and this is the overall patient. This is win, and this, the red one, is losses. And then we tested 20 apathetic patients, 20 non-apathetic, and 11 healthy controls. All were non-demented, non-depressed, and they are cognitively normal, within normal ranges, and there were no differences in any demographic variable, but only on apathy. And then we observed, this is the red one, is apathetic patients, and the other ones is control and non-apathetic patients. Then there is a significant difference, a significant diminution of the amplitude of the feedback-related negativity in response to these losses only in apathetic patients. And then, if we enter and dissect this information, then the amplitude of this sample correlate or was found to be decreased in this new sample. And these findings strongly support the compromise of again, of the mesocortical limbic dopaminergic pathway in the pathogenesis of apathy in PD. Here you have healthy controls, and this is the probability of making a risky choice in the next trial after you suffered a high lose or a high win. And then you observe that non-apathetic patients are risky-taking, and apathetic patients are very conservative. And okay, we can explain this, but still, these are just, I am going to the last slides. This is an ongoing study, and we say, okay, we have to observe, besides neurophysiological and cognitive evidence, some structural evidence of whether apathetic patients are different from non-apathetic, and still we took 20 patients, or 18 patients non-apathetic, 18 apathetic, and we studied the volumetric differences in the gray matter, comparing these two samples of patients, and we say, okay, those regions that show significant differences will be defined as regions of interest and correlated with other clinical variables. And here you observe that, again, the samples only differ in apathy. And then we observed, this is in preparation, of course, a significant reduction of gray matter volume in a set of brain regions, the nucleus accumbens, inferior parietal lobe, left superior parietal gyrus, left inferior orbitofrontal cortex, insula, and right supplementary motor area. But interestingly, we observed significant correlations, and very strong one, between gray matter density in the nucleus accumbens, that is related with all these tasks, and cognitive performance as measured with the Mattis Dementia Rating Scale, for instance. And then, arriving to this point, I have to say to you that we are used to confound apathy with depression. Apathy is not depression. Apathy can be clearly separated from depression using the appropriate scales, but still there is a region of overlap that make the clinician not very prone to recognize apathy if we don't use correct scales. But it is important to recognize apathy because apathy and depression has different effects on cognitive performance. It's classic that the patient that is with depressive symptoms perform worse than a patient without depression. But interestingly, apathy has independent effects on executive function, memory, and verbal fluencies that affects daily function abilities. But this is not the case with depression. That is, overlapping symptoms are different. And more importantly, the occurrence of dementia in patients exhibiting apathy is increased by many folds against patients who has no apathy. And then apathy may herald cognitive decline. And of course, there are no pathological studies of apathetic patients in Parkinson's disease, and we don't know which is the place that differentiates these patients. But this is a very nice study for the group of Glenda Halliday, and then they observed that you need increased alpha-synuclein deposition and hippocampal dysfunction to become demented in a setting of more widespread degeneration of cortical dopaminergic and cholinergic pathways. And then the only big differences between demented and non-demented patients in this sample are an additional loss in the lateral part of A10 dopaminergic neurons, as well as cholinergic deficiency in the CH4 nucleus basalis neurons. And perhaps it is possible that the additional loss in this lateral part of A10 dopaminergic neurons, that we have some indirect evidence with different paradigms that I have shown you, appears mandatory for the development of Parkinson's disease dementia and may also differentiate non-demented patients with and without apathy from the very beginning. Just to finalize, what about treatment? And there are very few formal approaches to treatment of apathy in Parkinson's disease. And as I've said to you, apathy is multidimensional, has many dimensions, and there are anecdotal reports of patients who improve with antidepressants, who improve with amphetamines, who improve with dopaminergic medication, but only 2 formal double-blind studies. First, we did this. We analyzed a big sample of patients comparing different treatments in well-matched patients, and the only interesting difference that we observed was that the percentage of patients with clinically relevant apathy was less in the group treated with dopamine agonists. Then the treatment with dopamine agonists may be influence the presence or the evolution of apathy in these patients, and this is in line with this double-blind study that has the bias that was only performed in patients after DBS, that their apathy that is presenting after DBS, that is not rare, improves in a double-blind fashion with dopaminergic agonist, that is pirivedil, that we have no here in our country, but the French people have. And the only one and completely different approach is with ribastigmine, showing that patients with moderate to severe apathy without dementia and depression may improve somehow with ribastigmine. And perhaps this is showing that there are different trajectories of apathy, that cholinergic influence is very important, dopaminergic influence is very important, and that both concurs not only to explain apathy, but to explain apathy plus cognitive impairment and a malignant trajectory towards cognitive impairment. My final slide is just to show that apathy should be added. We have to definitively place apathy in the roadmap of Parkinson's disease. And many thanks for your attention.